Welcome everybody. I'm from Umbrella Therapy Services, and we had like more than 300 clients waiting. So we thought, whilst everyone is waiting, we could at least do something for the family members, and that's where this idea originated. And we have been doing this training quite a lot. So Julie and I met in late 2019, 2020, around that period when we're doing online trainings. And Julie used to be a training leader from DIR FLOORTIME. She's still a training leader.
Kind of just delve in a little bit today and start with some foundational knowledge stuff to make sure that we're all kind of growing from the same page. And then we've got some other modules set up in the future to kind of break down specific topics. But I am like an interactive teacher and learner. So if you feel like you've got a question during the class, because we get the glory of having a small cohort, ask those questions as we're going along. Feel free to put them in the chat box.
From our end, I guess.
Yeah. Well, let's get started then, if we shall. So you should have had access to the slides in advance through the Google Drive that PJ sent you, but he's also put the link in the chat box if you don't have those in front of you. And we're just going to go through those slides, but feel free to utilize them as needed or just hide them, and I can ramble and chat at you for a good hour and a half. So we'll kind of expand the content on those slides if at all possible. This knowledge might be a little bit of, I don't know where you guys are in your diagnostic process, but one of the things I found sometimes when we work with families is even if you've gone through diagnosis, the knowledge around that process is also still a little bit like, we've got this and we don't know what it means. And so we've really decided this introductory course is really about establishing that foundation of knowledge, both around diagnosis, but also around what does autism mean and what does it mean for you more than what does it mean in general in life. So this is, we've labeled this Autism 101, but mostly with the focus of understanding autism as the focus for this evening. I've got a lot of letters after my name. Those are just qualifications that I've gone through as I've gone through my process. I also teach at a local university, so I have a fellowship in higher education as well. All right, next slide I think says introducing us, so we can probably just move through that one as well, I think. Or I think it says, who are we? Oh, the program for tonight, we're going to do our introductions. We started that a little bit. Then we're going to do some taught content for that first hour and a half. And then we've got 30 minutes of Q&A just focused at the end. So just a guideline of the roadmap for today. This is PJ and I. You've met us now, so we'll go ahead and continue on. PJ, can I get the next slide, please?
Yeah, so I was just trying to do that. Yes, here we go.
Okay, great. So this is, I'm actually, PJ, let's actually just kind of maybe use the chat box for this instead, because it's a screen share again from my perspective. So the question we were going to kind of talk about was, what does autism or autism spectrum disorder mean to you? And really just kind of like a vocabulary dump. So there is a QR code there that pulls up a Mentimeter. So maybe if PJ, if you could pull the Mentimeter up on your screen.
Yeah.
So if everybody can just take a second to scan the QR code if you've got a device in front of you.
Sharing, I'll share that in the chat box. There we go.
Yeah, you can also just follow the link in the chat box as well.
Oh, yeah, cool.
Oh, I never was a river. No, I'm not. So cool.
And then PJ, if you want to follow the link and pop that screen up for us, that would be fab. Things that relate to autism, and I can see the Mentimeter results here. And so I'm thinking, and you can add more than one word as well. But what we've got happening now is we can see things about language, communicating differently, a difference in thinking, neurodivergence, sensory sensitivity, and the brain works a little differently. And I think those are really great concepts for us to think about. And what I want to acknowledge for all of us is that the first word that comes to our mind is all different for us. And what that's telling us right now is that the experiences around autism are also different for us. And I'd like to start off, I do a lot of neurodiversity informed education, and so sometimes individuals prefer to be called autistic, and sometimes individuals prefer to be person first with children with autism. So I will probably flip back and forth between that vocabulary through today's session. So just know that that's coming from an informed place if I refer to an autistic adult or an autistic child. If you can just go to the next one, please.
Perfect.
Great. So what we're going to start talking about now is what actually is the autism spectrum disorder, and its terminology and focus, really. And as you can kind of see, it's taking all of these little rainbow pieces, which I think are the things we've put into that Mentimeter, and kind of coming with an outcome that is then described as autism. So what happens when we look at autism from a medical perspective is that it's really chunked into these three categories of differences. The first being, and something that came up with a lot of your comments about autism, is that social communication. And you might have experience with this at home now or with individuals that you know. So the eye contact being something that's a little bit of a difficulty sometimes, conversational differences, and this idea of interpreting emotions, and that's both internally and externally that we're seeing the commonalities around autism being. And the next part of that next bubble of what makes autism is a repetitive behavior or interest, and that looks very differently. It can be stimming, it can be a routine that needs to be happening, or it can be an intense focus on specific topics. I always like to say that as a 46-year-old white woman, I didn't necessarily know that I was going to know as much about Pokemon and Thomas the Train as I do until I started in a pediatric practice. I also know a lot about John Deere tractors because the kids that I work with had a very special interest, and so we would delve into that together. And then the final thing that really qualifies this medical definition of a diagnosis is the sensory sensitivity, and it's either an over or under responsiveness to this sensory information. And so what you can kind of see at this point is that this definition really is based on observable behaviors, right? So what we're learning about it now is what the brain looks like and the differences in the brain, but the diagnosis is still very much done based on observable behaviors. And so really it's a little bit of a tick box of these three different categories. I would like us to start thinking about, from an intervention perspective or from an occupational therapy perspective, we look at it a little bit differently in how we're trying to support it. So what you might do is you might go through the diagnosis perspective, and if you're comfortable sharing whether you have or have not gone through this, that's fine. I don't want it's a small group. It feels like I'm putting people on the spot a little bit, but more the aspect of why is it important to have this diagnosis, because it can be a little bit of a journey and experience to go through this process. And really the rationale for finding a diagnosis is that it kind of helps us to understand those patterns of observable behaviors. A lot of autistic adults will say, oh, if I had only known that there was a reason for this when I was a child. It also starts to kind of create access to services for support. And unfortunately, that's a bit of a hard truth, is that a lot of times you do need the diagnosis in order to be able to access services. PJ's nodding his head, and he'll know more about that Australian process than I will. So I'll give you a second to jump in, and PJ. And then also it kind of improves communication and relationships. I work with a primary school population sometimes, and I've got a little guy, and he'll go, that's my autism that makes that hard for me. And so he's able to tell other people about that as well, and that makes that a really nice journey. And also for parents to be able to explain to others why that might be part of the difficulties or the behaviors they're seeing in public. PJ, did you want to add anything to that rationale within your context?
Yeah, I think you did mention it around services. Yeah, obviously we have a lot of changes that's coming in NDS space, and it's pretty up in there in terms of the Thriving Kids that's going to kick off in mid 2026. That's more in relation to in a milder or moderate form of autism, so level 1, level 2, which we'll get to in a minute. But I think those kids will be going towards more thriving kids, not NDIS as such. So that's what, that's what we are aware of now. So what that means obviously NDIS, since 2014 when it was introduced, it was a massive shift because lots of kids who had only limited funding from Medicare and also from better access funding. It was really limited funding. There's not much we could do. We could hardly fit in 12 to 20 sessions max. But again, everyone's need is different, isn't it? And it was really tricky. So since NDS, a lot of things have changed. However, for someone to access this funding, we need a diagnosis. We also need adaptive behavior. Adaptive behavior question needs to be completed. We need to have that functional level in order to in order to access the the services. So what happens normally is you get a diagnosis, and then you go to an OT who does functional capacity assessment and puts up, okay, these are the these are our things that we need to improve on, and based on that, funding is allocated, especially in this system that we operate in. Yeah.
Thank you. It is I now have been through the US and the UK system. It is firsthand knowledge is always much better than a research Verona. So really thinking about how that funding comes out.
Yes. So please feel free to ask questions if you have any, and if you're not there yet, please let me know, and I'm very happy to make it clear. Yeah.
Yeah, fantastic. So at this point now, we've started to think about why a diagnosis might be important, and you guys might be in any different one of these roadmap steps here, or the beginning or the end of it, really. But often what we start is with a screening, and that might just be a parent that's saying, oh, something's a little, I've got some concerns here, right? But often teachers and pediatricians kind of have that screening at developmental visits. Or, I think post-COVID for us, that was a big moment when a bunch of 3-year-olds all of a sudden were back out in public and hadn't had that developmental screening from 0 to 3 in person. So a lot of the referrals started to increase. It's weird to think about COVID because it's almost not an issue anymore, but boy, was it life-changing when it happened. And then the screening process might happen, and it will be, kind of a checking in. It might be a referral for an evaluation. After you've gone through the screening process, you might get a referral for an evaluation, or you might straight go to going, oh, I think this might support. There might be some things we could do in school to help support with some of those needs. So you might see a screening come through that. Then there's a formal evaluation process, which may involve either your therapist or a developmental clinician or a doctor that's allowed to do diagnostics. And then an evaluation outcome. So you come out with a diagnosis or treatment recommendations. And we're going to go through a little bit about what a diagnosis might look like in a second. But PJ, did you want to add anything to that process before we moved ahead?
Yeah, so as you indicated, normally, when parents have concerns related to some changes in kids' behavior or in terms of observable behavior when it gets noticed in childcare, and sometimes the developmental nurses, in Australia normally, they get screened by developmental nurses who are all trained to pick up these symptoms. And there are really good apps as well. AS Detect, that's one of the best app that I use, or I recommend people to use. So you can literally see the videos, and you can rate your kids. So in terms of whether they have any red flags, and that can be quite an indicative of further inquiries around whether there's a signs and symptoms present for us to be further diagnosed. So that happens, and then when it comes, so normally if the pediatricians are able to see enough in terms of the presentations or observable behaviors, then they may do the diagnosis there and then. If not, they may send people out to us, so I'm trained in ADOS and ADIR. So we do diagnostic testing here as well. So we do our diagnostic testing, and then we provide based on, so we have a set of toys that we use, and we do lots of, we use ADIR to interview parents, all the developmental checklist, And then what we tend to do, these toys are designed to elicit certain response, so observable behavior that we look at. So it could be, the way we speak, it could be the use of our gestures, hand movement, or whether we are maintaining, whether accent, So there are a lot of things within the checklist that we look at for us to say whether we meet the threshold or we don't meet the threshold based on the behaviors that we see within the checklist. Plus, we also go back to the childcare, and we do observation there and see what are the challenges that the child may be facing. And based on that, we gather those informations and we send out sensitive questionnaires, parents to respond to that. So we get that part of the information. So we collate everything, and then collectively we rate the form, and the form does tell us whether we have the rating is high or low. Based on that, we provide information to pediatrician, and subsequently diagnosis is made, or the diagnosis given by the pediatrician in the Australian system. So it could be done by speech therapists who are trained, or it can be done by single person diagnostic. That's only pediatrician can do it. Or it is a multidisciplinary team. So normally in our team, we usually involve 2 clinicians so that we are not missing out any information. So we ensure that when we do the diagnostic testing, we have got 2 clinicians doing the observation, and we have a discussion subsequently. And once we do that, we invite parents to talk about it, and then discuss our findings, and then we send out the reports if they consent to do so. Yeah, so that's how we do it here. Any questions from that? Perfect.
So this is just kind of following on from that medical model of what does this spectrum mean, because it's been called ASD, or autism spectrum disorder, for quite a long time. And this historical and diagnostic perspective of using the spectrum, sorry, is that prior, you might have heard terms like low and high functioning, and I won't even say prior because it actually is still a lot in current practice. People are using the terminology high and low functioning, but we are trying to move away from that with the greater knowledge of neurodiversity informed practice. And this is kind of translated into diagnosis now. So initially there was this concept around it, and now it's moved to this diagnosis of how much support need does a child need. So it's not the functioning level, but instead it's now transitioned a little bit into the support needs of an individual. And on our next slide, we've got a little bit of a summary of what those levels look like within the Australian diagnostic system. Now, a little bit more of a contemporary perspective, or I might say a little bit more of a therapeutic perspective, is that we're now going to start to try and open the discussion about looking at the individual components of the individual that create this level of spectrum presentation, really. And with that focus in mind, we can really transition more to like a strengths-based mindset. So which of these things are easier for your child or yourself? Which of these things are more impactful in life? And it allows us to kind of start to address some of the areas of vulnerability, so we can kind of see which things really are in a day-to-day life having some real impact in what's happening. So we're going to start moving to that idea of the spectrum is actually just a different presentation of a bunch of different pieces of a child or an individual. But first, just a quick review on the Australian diagnostic levels, which is, I think, the next slide.
Sorry, I haven't started recording. Can I start recording?
Of course you can.
Oh, started automatically per the meeting organizer setting. Perfect. It's recording. Sorry, I thought we have not started recording yet.
PJ needs a Teams 101. We're going to get you a Teams 101, PJ, on meeting settings.
I'm happy to join the training. All right, there we go.
So this is generally the general diagnostic descriptors, and so I'm hoping if you've received a diagnosis, someone has kind of explained these through to you, but you might still be in this process. But we often talked about, it's often talked about, oh, this child, this child has autism level 2 or level 3, or even just a level 1 diagnosis. And you might have heard the terminology about Asperger's syndrome in the past, and that would be someone kind of leaning towards a level 1, but it's really moved away from some of those diagnosis labeling. So just a kind of review, that level 1 just requires a mild amount of supports, right? So you might have some distress and some inflexibility, a little bit of social challenges that might seem a little bit non-traditional, and some difficulties with some back and forth conversation. A level 2 diagnosis would then be moderate to high support. So there might be some verbal or nonverbal deficits in communication, so difficulties there, and a limitation in social initiation. So just that starting of those interactions, and some very observable repetitive behaviors. So stimming or scripting, where you repeat phrases from movies and TV shows, and a difficulty coping with unpredictability and change. No, a difficult coping with changes and predictability. Stick with me here, we'll get the vocabulary out. And then level 3 is a high support need, so substantial support, so significant communications to severe communication limitations. You might be using AAC or alternative communication devices at this level, and we see some really repetitive restrictive behaviors and distress with change. And so that being said, within those components, there is a little bit of wiggle room about of how those diagnoses are achieved. Did you have
it's not unusual for like a kid to go from like a 1 to 3, because like my son earlier this year, like he was like pretty much always a 1, and then he had a teacher change for 6 weeks, and like everything just went chaotic, full blown, like into category 3, and yeah.
Yeah, I think that's what I would, kind of the point that I'm making. And it looks like PJ wants to talk because he's put all of our pictures in the middle of the screen again. And so what I'm thinking is a little bit around, hopefully, Joel, let's hold on to that question actually, but it is very common for kids to have fluctuation in their needs level based on what's going on in their environment or in their selves a little bit. Sometimes it's like, I'll have when I was working in a practice where I was seeing 35 kids a week, and you would almost see cycles of it, and it would be like, oh, it's allergy season. Oh, it's this kind of year. So sometimes it's internal and sometimes it's external, some of those changes in need. PJ, did you want to add something to that?
Yeah, it could be I think our upcoming trainings that we have designed, it does answer your questions very well. But I think quickly, it could be the relationship with the teacher. It could be the changes that has happened. It could be his age, his puberty, whether he's going through that.
So I think there was a couple of little changes, and it was like his coping mechanism went from being here to me having to go to school twice a day. I mean, from not going to school at all to a couple of days, a week, and now it's been like 2 months since his teacher's been back, and I haven't been to school for 2 months. Yeah, because he's been coping, he's better with it.
Yeah. And and what starts to be a little bit different is that the repair from the coping can be a little more challenging than would be if something happened significantly to you. You might be able to recover quite quickly, but with our kids who have such specific challenges, sometimes it makes the recovery can be a little bit different for them. So let's keep talking about that, Joel. And as we go through, we are going to kind of break down some of those topics and maybe help you kind of figure out, hopefully, a little bit of where that challenge might be coming through. So we're going to encourage you, and I like to use the word challenge, but it's not in a defensive way, to start thinking a little bit about autism outside of those 3 bubbles of social communication, repetitive behaviors, and start to think of it as not a linear spectrum where we're thinking low functioning to high functioning, but actually starting to think about these individual different components that might be impactful on yours or your child's life. And so we're going to kind of go through them a little bit. I've got a slide where this next slide has the pie chart in a slightly bigger way. And so we're going to go through these different categories and talk about them together. So PJ, I'm going to ask you to go to the next slide. And so I've made one. This is just all of us. All of us have a place on this spectrum. And if I could draw on my slide, I was going to do this with me. So I'm just going to ask you to visualize this with me a little bit. But I'd like to kind of talk about the different 8 categories that we're going to discuss here. And those are the 8. There's an other there because each child is really individual. Each person is really individualized. So perception, let's start at the top. We're going to start way up at the top here. Looks, I think I can draw PJ. Hold on.
Yeah.
Okay, fab. Okay. Thanks, PJ. I wonder if I can I move my marker bar? No. Okay, so interests. So for me, interest in have a pretty significant part of my life here, right? So I like to talk about the things I like to talk about, but they're not in fact in my daily functions. So they're right in that middle area for me, and that I'm willing to share them, but I'm also willing to listen to other people's. Now, I'm about a 5 or 6. Hopefully I put a 5 or 6. Now a 10 might look like somebody that's really impactful in their life. They can only talk about their choice, or they can only engage with their specific interests, right? So we're going to move to another. We've got a slide for you and a slide for your child coming up too. But so interest for me is it in the middle. Repetitions is very low for me. I don't really engage in a lot of repetitions. They don't require them. I can be quite flexible and reactive, so I don't need a lot of routine in my life, with the exception of taking my morning medication, which if I don't do it that day, I will forget for the rest of the day. So I do like that cycle of repetition for that. Sensory sensitivities is one of my higher ones. I've got a lot of environmental allergies, so that really can be impactful in my regulation during my day. I can get a little bit more irritable if my sensory sensitivities are picked up, so that means I get itchy, and those kinds of things can really impact my interactions and my ability to get through my day. Emotional regulation, I'm a pretty stable gal. I don't get riled up. I don't get too reactive very quickly, so that's not having a lot of impact in my day. I can stay pretty steady and calm even on the itchiest days. Perception is an understanding of other people or other environments. And so if I was someone, so I'm going to also rate myself quite low here, in that I do a very good job of reading. Well, I like to think I do a very good job of reading other people's emotions. If I was sharing the slides, you guys would be dead irritated by now, because I stop sharing all the time so I can see people's faces, because what I really like to do is see the perception of what's going on. So it's interpreting the environment might be another way to think about perception. Executive functioning. Now, I will tell you, this has a pretty significant impact in my life. I'm actually going to go up here maybe, because my working memory is horrible. And so I'm constantly taking notes in books. So executive functioning is, I would like to think about it as cognitive skills. That might be a better way for you to kind of remember it. So it is things like working memory, impulsivity, attention and focus. That area goes into executive functioning. And for me, memory is a huge issue in life. I've got 15 notebooks scattered around me on the ground right now, but it's that new working memory. So the memory that I need to hold for a short time period and go through something. So I'm the girl that walks into the room and forgets why I'm in the room unless I repeat it to myself in advance. I think it might be age related slightly, but that's probably not much explaining.
Could I ask a question?
Yeah.
Would it
Go
be
ahead,
okay
please.
to ask a question about the perception part?
Sure.
I have a daughter, so she's female on the spectrum, and she's 6. I would say that she's like hyper vigilant to perception. She's not very good at it, but she really, perhaps because she's a girl and she's socialized to be more perceptive of others. She's pretty terrible at perception, but I can see that she's trying really, 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 really hard, and it's like quite almost obsessive, I guess. Where do you sort of? That's still kind of difficulty, I guess, isn't it?
Yeah, so I would put it quite high for her then on that one, because really what I want you to think about is how much is it affecting them during the day, right? And that's what you're kind of ranking it at, because I can be sensory sensitive. I just said it for right now my sensory sensitivities are overwhelming a little bit. But on a general day, I might only be at a 2 or 3. And so it's not really affecting my day. But if that seems like it has a really strong impact on her, I would rate her higher on that. It's especially if it's taking a lot of her energy, right? So if we only to quote Taylor Swift, let's all pretend that your energy is expensive, right? And so you only really want to spend it on something that you need to. And so she's spending a lot of energy and perception, it sounds like, and that might make some of the other things more difficult for her. So we'll continue to talk about that. And it's really a fascinating, sorry to go down the intellectual wormhole, difference in female and male autism is that these socialized norms are coming out as the masking is different for them. So that idea that we don't actually know if the ratio is that different between boys and girls, and that's really a study that's going on right now, because it's always been the presentation in boys is so much higher, and now they're rethinking it as, is the presentation just so different that we haven't been acknowledging it? So that's really interesting. So we've got perception, right? We've got our executive functioning, we've got our sensory sensitivities, and then social differences kind of comes in. And that might be like the way that you initiate interactions with somebody differently, right? So do you, are you comfortable using eye contact? Are you not? Do you understand the nuances of things like, oh, good morning, how are you? To start an interaction, as awkward as it can be, do you understand that? Does that person understand the back and forth pacing of things? I am an American in rural England, and for now my social differences are quite small. But I would say when I first moved here, they were probably middle, because the introduction of self is very different up here. People don't walk in and shake hands and say, hey, I'm Julie, it's nice to meet you. You absorb yourself into a social circle until you're interesting enough for someone to ask who you are. So the social differences can be impactful. And so I wanted to kind of go through this this wheel as my own personal experience, because I'm not autistic. I don't have a diagnosis, but these components of differences affect all of us. And then we've put other into that category there because you or your child might experience something that you really feel is very big in your day that isn't identified in one of these other seven categories. And if you have that moment, you will know what that other is already. So I just want us to think about what this looks like as a different kind of spectrum when we start to think about strengths, when we start to think about impact on the day versus that observable behaviors that a medical diagnosis would kind of come from. So my next little challenge to you is the next slide, where I want you to just think about yourself a little bit. So we're going to go to the next one a little bit to plot ourselves here. If you have a piece of paper in front of you, if you want to just do this cognitively, I don't mind, you can use your brain, but think about yourself on your given functional day, and which one of these feel like they really impact on your day. You're all the way up to a 10. Which of these just kind of are easy for you, don't require a lot of energy, you're down in your ones, and start to kind of give yourself a little bit of a plotting there. So if you're comfortable, obviously I've chosen red, which is not my favorite color, but start to think about what are the things that are really big for you and take up your expensive energy during the day. What are the things that are impacting the most on your energy?
There we go. Yeah.
I have two 12-year-old girls. There's a lot of Taylor Swift in our house. I apologize for the quotation for Taylor Swift there.
No, lots of us is a big fan of Taylor Swift as well. So
she's taken over the world. And I think it's so good for us to think about these are all the different things that we're requiring at any given moment of any different day. It's, all these things that we're trying to balance as we go through, and we'll start the conversation tonight, but we will start to break these up into our you know, the next few modules, or next week, we're really thinking about the sensory component in a strong way. And then the following week, we're talking about communication. And so that social differences piece a little bit and how to support it. So we're going to start pulling the wedges out a little bit as we break it into the next 5 weeks of topics. Executive functioning and behavior come toward the end of it a little bit. But I want you to think about this wheel and kind of hold the image of where you are in this wheel. And then our next slide is thinking about the child, or you know, I always use the generic play partner, because some of you might be not here as a parent this evening. And so thinking about your wheel, holding that, and then our next slide, and we're just going to give it just one more minute here, is thinking about your child's wheel and how different that, and how that looks for them. So you might not know all of these different components based on the ability of your child to share some of this information with you. But we want you to start thinking about, where do you think the impact is the greatest in your child's day? Do we think we're okay to move to our next slide? And then after we do our plotting of our children or play partners, then we'll take a quick comfort break and then come back and go into that. What are the next steps once we start thinking about these things? I'm going to go, my other for this child is definitely going to be the awareness of her own personal hygiene as she's going through puberty, of I need to shower more often, and all of those things. Seems to be a lot of conversations we're having today.
For the DIR user, DIR, I also got 14 years old, so I can relate.
It's like, you know, it's like I appreciate it. Their bodies are changing and their awareness has not quite grown with them. And then it causes emotional regulation when I comment that maybe we need to have another shower. Yeah, so she's quite high in emotional regulation now, and my other is personal hygiene as a big impact on life currently. Not in the fact that she has poor personal hygiene, but that it's taking a lot of her energy to think about it right now. Okay, awesome. Thank you guys so much for sharing all of this. And you can see some of us, all of us take about, what do you think, PJ? Do you want to take a 10-minute break so we're back at 1:15? Would that be good?
I think that's a good idea.
That leading question is does your wheel, hello, sweet girl, does your wheel look the same as the other person's wheel you've just finished? Does it look different? And how does it feel if some of those wedges don't quite match at the edges, right? So does it help your understanding if your chunks of your pie are the same? Does it help your understanding if they're a little bit different and you can balance each other's out in your strengths and interests? So I'm going to leave you with that kind of exploratory question as we go into break of, did you find that your wheel looks similar or different? And there's no right answer to that one because they're all of our own wheels. So we'll leave you with that, guys. Go take a little bit of a comfort break. Joel, are you comfortable telling me how old your little guy is? Oh, you're gone again.
Yeah, he's 6.
He's
Oh,
6.
just about 36. Yeah, November. 6 going on about 22, I think.
Well, hopefully as we go, we'll be able to kind of support you around the different areas that he's struggling with a little bit. It's a learning curve for everybody, isn't it? I always say, like, in these meetings, like, the best experts about autism are parents, because you guys know those intricacies of living with it daily, to be fair, but also your own child's, wheel, really, it changes for every single person we work with.
True.
Yeah, I think it's shocking to me, actually, because I've always been a practitioner that has parents really quite involved in sessions and intervention, but I know there's a lot of experiences out there where it's just like the therapist takes the kid for an hour and we don't know what they're doing back there. So hopefully we're kind of sharing some of that knowledge with you guys today to help support your understanding what we're doing. Okay, I know James is having some dinner and bedtime stuff happening in his house, so I'm just going to go ahead and continue on with where we were as we come back. So hopefully we've started thinking about these different components, and we have we'll continue to have those as topics of discussion as we go through. But now that we have this like understanding of the individualized spectrums, as you might say, or wheels for each of the individuals, then we're going to start to think about where it happens next, really, and or what does this look like to other people. So we really asked you to kind of give us a thought about what's going on internally for yourself and for your individual child. But this some of the things that we might hear from others, right? So those others being just a general observational presentation, or if someone comes to us with a referral for an evaluation saying, this is what I'm seeing. And it might be based on what that pie chart is. And so really kind of that idea of that there might be some emotional regulations challenges. It sounds like some of you might be experiencing that now, where little changes, big changes, everything is having a big reaction, right? And it might be, sometimes it's centered around transitions, sometimes it's centered around predictability changes, but that might be something that's that's brought you or your child to the forefront of something's happening here. Those sensory differences come forward really easily. So, really dislikes being messy, or is constantly banging into objects. And in the second class in module 2, the first class we're going to talk about is sensory differences and what that might look like through all of our senses. Those communication challenges come to the front point. Sometimes, he doesn't know how to play with other people might come in. So we'll think about communication challenges as something that might be an observation that comes through to us. Relationship-based difficulties. How does that work? How are they navigating friendships? How are they navigating adult-child interactions? How is that supported around the child? Thinking and learning differences. And so that might be one of those things that, this special interest, this child knows everything they can possibly know about. One of the little guys that I'm working with right now, the periodic table at, age 9, has the entire thing memorized. So sometimes that thinking and learning difference is a very highly intellectual specialized knowledge. And sometimes it's things like having a hard time remembering what direction somebody was just giving them. So it can go both ways when we think about these. And I want us to think about them as differences as much as we can. And then sometimes we see some behaviors of concern, and we're going to go into that a little bit deeper. But that, what we try not to do is label things as like aggressive, but we think about the sensory components. But you might see things like, head banging, biting, frustration tolerance, those kinds. We might see those, a teacher telling us about one of these things, or a parent, or possibly a member of the child's interaction with their pediatrician or doctor. And it might look like in practice anxiety and fear. So when we're thinking about, those sensory differences, what it might look like is a child who has a lot of anxiety and fear around going to school, around changing environments, around new people. It might look like attention and focus on both ends of that, where it's like very intentional attention and focus, or a lot of distractibility and lack of attention and focus. So these little pie wheels then have these observations, and in those observations might really look like in practice this need for control or sameness. Sometimes you might hear that word in practice called rigidity, where it just means that need for control or sameness, but it might be coming from some of these other underlying reasons. And these special interests that if you have a speaking child, you will know readily about the things that they choose to kind of discuss with you. It might look like some social or sensory preferences. There's sometimes a preference for playing with younger children because the play is simpler and more manageable than getting into sports and playing football on the big yard or those kinds of things. It might look like transitional challenges, so that difficulty moving from one task to the other, or moving from one environment to the other. It could be food-related challenges, so very particular eating preferences. Limited diet might come into place. Texture might be an option in that one. And a little bit of that perceptual identification of understanding those social cues, really reading the room, and how does that look for each individual. And then within those, this might look like there are some more common presentations that I'm going to let PJ talk a little bit about, and that boys and girls very interestingly differ in what the presentation of autism might look like for that individual. And that's a lot of actually the current research is going around what is the difference in the sexual characteristics of autism. So
I guess, like when we look at clinically, what we tend to see, or what we see in the outside, is autism sometimes comes by itself, but sometimes it does come with other conditions like ADHD. And the research indicates up to 50 to 60% of the time, ADHD is combined. So what I often see in our girl child is, maybe the hyperactivity component is not really overt. It means you may not see it, but inattention component is really impacting. You know what I mean? So if you're not interested in certain subjects, so for example, I had someone from year 7 coming to me. She loves snakes, right? She loves animals, right? And then every time she goes to school, the school cannot accommodate, in terms of her sensitive preferences or her interest. So she gets really inattentive. She can't attend. Yeah. So as soon as there are a lot of advocacy around, okay, how about we adapt the curriculum based on the interest? And I did a bit of adaptations, had a bit of meeting, and then there she goes, starts learning English, starts learning science, because everything could be adapted to certain, to that interest matters. So I think it's very important for us to understand what it looks like, but also this could be one of the strengths, that we can use to support our kids. So, sometimes we see kids lining up toys. So obviously in our upcoming sessions, we're going to understand why does that happen? What's behind that? And it could be just like not being able to, plan or execute things, or having a simple planning and sequencing. So other thing that we often see, the sensitivities we did often talk about and parents report, is going to shopping malls in a crowded environment. And we know Coles and Woolies, they have a period of dim light where, the shopping is possible early in the morning. Yeah, so they do up until, I think it's 9 to 11, a couple of hours, they have got a window where they dim their lights. So I think those are very important factors, because if you look at all these sensitivities, it does impact on how we function or how we perceive the environment and what sort of feelings or anxiety we may have following that, or it could be a traumatic experience for some of our kids. So we may have a special interest, games, and that could be a way of venting out, or we may be fearful of drains, or have this fear that we feel, why you're not going out. It could be the birds. I had a kid who was extremely fearful of birds, and that stopped her going from school. I had kids who had fear of butterflies, and that stopped her from going to school. And then we often see very, as Julie mentioned earlier, is special interest, Star Wars, Minecraft, these sort of characters, Pokemon. We see these, and themes around that could be a strength, which I'm going to talk about in upcoming sessions. And if you can see this in the classroom environment, that we may look different and we may get distracted because it's not of my interest, or it could be something it's too hardly presented to me, or maybe my sensitive system is not being supported. So there could be a lot of elements behind what's on the surface, right? Next slide, please. Any questions so far? No problem. All right, so I think, so in our upcoming sessions, we're going to deep dive into the interventions, and understand the individual differences that we talked about already in a more like a dissecting it and understanding it. But for now, I would like to highlight that there are approaches were behavioral driven. Yeah, that means it's pretty much based on what you observe on the surface, right? And there are approaches who are driven by relationship, right? So I have, and obviously Julie and I had this lot of conversation around this many months ago, and I asked her experience around behavioral model, and I had the similar experiences, and I think a lot of autistic think in the same way. So what I'm trying to say here is behavioral model, which I was originally trained, and I did that ABA, in applied behavioral analysis, we call it, and I did implement that earlier in the career because that was what we learned from the universities, and we implemented it. Something didn't sit right with the model because it was more of a my planning. So I was deciding what the child needed to learn, or I was deciding how the child needs to behave, and there's no consideration around what the child likes, or the interest of the child, so there's no motivation. So we used to see lots of behavior, and there was techniques that was given to us more like a reward system. Okay, if the child does this, you give this reward, or every time child does something, you need to tick boxes. So imagine you're trying to play with a child and you're ticking box on the side. So how it may look like, so I was quite frustrated. Sorry, I'm talking about my journey as well. And then in the middle, I found this model called Early Start Denver model. So what Sally J. Rogers, who has created the model, what she has done, she has pulled floor time, and she has pulled behavioral model, and she did something in the middle. Now I can see it because, obviously I'm trained in DIR floor time, and Julie and I, we both are expert training leaders, and Julie has been a training leader for a very long time. So what we see is in that model, obviously there was components of relationship, and that was really strong. And then there was a components of behavior where you still needed to record all the surface behavior. So that did work somewhat because I had, we were able to do a lot of things. But at the same time, sorry, I'm just muting one of the participants. At the same time, what was happening was all the activities I did was predetermined. We had to do this and this and this and this to get to this. Yeah. Even though I was using relationship, still the control was mine. So for example, if I had to elicit a response, I'll hold everything back and get the child to respond and then give it back. So there was a lot of things within that model that did not sit right. And eventually, when I got into this floor time model in 2019, and journey began then, and up until 2024, where I did my expert training leader course, and thanks to Julie for support throughout. Well, but what I would like to highlight is it completely shifted my thinking process as a therapist, right? We used to go with the pre-planned ideas. Okay, this is what I want to do, right? But then that changed because I could see what the child was interested. And when I could see what child was interested, I could get into child's interest and then get the child to be interested in what I was interested in, right? So this model where relationship is very, very crucial. It means if I have a relationship, which may take 10, 14 weeks or sometimes a year, but if I have a strong relationship with the child, that means a lot of things that they learn can be easily generalized, right? So a lot of the time the teachers are like, when I go to school, they're still using behavior. A lot of schools still use behavioral model. They use, box system. They use, okay, this is what they need to do. This is what they need to draw. This is what they need to trace. But then when I showed them the video that I have done in the session, they were like, wow, the child can talk so much. Yes, the child can talk so much because I'm following the child's interest, right? So again, these are some of the comments that I would like to make around developmental model, right? So to show you the critical differences, so developmental model mostly focuses on developmental capacities, we call it, which we learn in our optimum sessions. We focus on emotions, we focus on relationship. Whereas in the behavioral model, we focus on what's seen, what's observed. Was the child able to stack 2 cups? Was the child able to stack 3 cups? Was the child able to sit and eat food on the table? So these are the monitoring factors for the therapy to be successful in behavioral model. Yeah. So other thing that I I often try to say is behavior seen as a communication and developmental signal. Behavior is something the child is trying to communicate. Something is child saying something is uncomfortable for me, and we respond. But a lot of the time when we do relationship model, we have minimal to no behaviors. That's what I see, yeah, in the practice. Whereas, we used to pull our head apart. I was bitten on my back, a lot of the time earlier on in the, when I used to do this sort of model, behavioral model, because it was really, really frustrating for the child. And now we know that there are a lot of research, a lot of evidence, increased post-traumatic stress disorder, which child exposed to applied behavioral analysis. And you can see, we have put down the article for you there to reference, but it is very important because when we are starting our journey to understand and be informed, what's the model? I'm not, obviously people have preferences and choices. I'm not telling, we're not here to tell you what choices to make, but as a therapist with 20 years of experience working in the field, what I'm trying to highlight is what is stronger. Where do we see massive growth? And a behavior model often is really hard. So for example, in this setting, in the clinic setting, if I'm making the child to sit in this chair and do certain activities, the child may master it, but it's really hard to generalize this in different setting. So generalization of the skills gets really, really tricky in behavioral model as well. So something to keep in mind. Yeah. So look at this, that we have got a kid's photo sliding down this, slide in lots of fun. So one of the family recently came to me and said, why is your therapist, I'm one of the senior therapists, I do supervise a lot of junior therapists. Why is your therapist smiling so much? My child is 80-year-old, and I think it's not really right that the therapist is smiling so much. You know what I did? I was on the call. I said, I had to pull my car and talk to the parent for half an hour, saying that the therapist was trying to build relationship. Yeah, if we build relationship, any obstacles in that journey becomes easier. As we get to learn that how part in our upcoming session, but with that explanation and with that the theory behind firing and wiring, because we're trying to fire together to wire. I think they're so happy now in terms of why they choose to come and do the therapy. Yeah, and especially the development model that we mostly cater here. So therapists in development model, they're more like a responsive partner or co-regulator. So we share our regulation with the child for the child to thrive in that environment. Whereas, so in the behavioral model, therapist acts more as a trainer using reinforcement, as I mentioned. Yeah. Goal for developmental model at more holistic development, emotional regulation, engagement, joint attention, social problem solving, and being able to problem solve, these sort of things. That because if you see in our life every single day, even now when Julie and I was presenting, we had a problem here, right? So I could not figure out how to share the screen, and we all were frustrated to some extent. But what did I do? Obviously, Julie used an idea that, hold on, we can do this in a break. And I was persisting to get this rectified. But think about the kid. Every time, I need water, I need to solve a problem. I need this, I need to solve a problem. Oh, everyone is different, I need to solve a problem. Teacher puts every single day they go to school, they get catered with different curriculum, or different things to do, different activities. I need to solve the problem. So if you see in our real life, we have full of problems because we use all the things that we have discussed earlier, like executive functioning. We have less sensory differences. So with that, we're able to navigate those issues and challenges which happen, and that's what we train in a developmental model. But whereas in behavioral model, it's highly structured, adult-led, and data-driven. It's all about data. And if you see a lot of researchers, they say, okay, we have done this many improvements. Yes, that's because you've been ticking boxes all along, and there's no time for making and bonding with the child, right? So, but what we know in research is, as I said, firing and wiring, which is which we know, neural pathways developed through firing and wiring, which happens in developmental model. Yeah. So I guess I can keep talking about this, and I probably will take the whole 1 hour to do this, but I would like to move on. So can we go to next slide, please? Any questions from that? Yeah. Sorry, I'm big fan of a developmental model, and that's with the experience and what I see. Yeah. So what do we do? What do we do, and how do we do it? Obviously, it's very important to look at, as I said, the earlier example of a little girl who was struggling to go to school, because none of the topics that were covered was of her area of interest, right? And she had to force herself to be there. She had to be medicated because she was feeling anxious. When she wouldn't do it, she would get into trouble, from school. Yeah. And then we started talking about, okay, she's inattentive. Then, she was medicated for anxiety. She was medicated for, inattention. As soon as, but she can sit in a session and talk about snakes for an hour. She can give me everything about snake. And I have learned so much from her, the depth of knowledge. But I was like, okay, what if everything can be catered around pets that she likes? Yeah, just that's a question for all of us to, think about. Yeah. So that leads me to another one. So presuming competence, right? So this is a really, it's a really philosophical, but very important point to notice here. So for example, if you're trying to play a video game, right? And then all of a sudden, the controller is not working, So people who do not presume competence, they may say, you don't know how to play a game, even though I'm a really good player, right? I can play video game really well. Because my controller was not working on that particular day, or it was laggy, people thought that I can't do certain things, or people had an opinion, right? So let's take this in a different way, right? So what if we are presuming competence and have that framework or glasses that we put on, then we'll see as people, okay, there's an issue with the controller. Let's rectify that, and then we can play the game. And I can see you're a really good gamer, right? So this is very important in our way, So again, presuming competence applies to the later example that I just talked about, isn't it? So think about if we, and we do have a lot of research and a lot of individuals coming. We thought a long time ago that they can't speak because they're autistic, level 3, they can't speak. But what we know with the development with the technologies, and when you provide them with ACC devices, special devices, now they are communicating. People thought I'm dumb, remarks like that, but I'm not. I remember what you have done in this date, and I didn't appreciate that. This is all coming from autistic individuals, right? So what we're trying to say is presuming competence is very important. But then the methods that we're using then and now may not be the right method to teach, or they may be struggling quite a lot in that particular environment. Maybe maybe I don't have enough relationships. I had a training yesterday in one of the schools, primary schools, and we talked about an support teacher, like a TA, teacher's assistant, asked me, what do I do? And I can see a very chalk and cheese between her and other TA. Other TA engages quite well. This TA in particular doesn't engage. And I could see the differences. You know what the difference was? Can you guess it?
Presuming competence.
Exactly. Presuming competence. And other very important difference was relationship. There is such a lovely relationship with this TA, and the child does a lot of things. Jules, going back to your question, the earlier question as well. Yeah. So investigating the relationship. If we spend a lot of time in relationship, a lot of things, we can make the child feel safe. A lot of things may happen because we are relaxed when the relationship is really nurturing, caring, and loving, right? But when we are not relaxed, even now, if we're not relaxed in this environment, probably I'm a little anxious today, obviously, given, the presentation and training that we're doing. But then if I'm not really relaxed, then I wouldn't be able to do what I'm doing right now, right? So that applies to all of us. But then again, for our kids, because of the differences that we earlier saw and that exercise that Julie, initiated, we know those all things does impact on how we function. So other part is neurodiversity affirming language and practice. And this is really, really important because getting the language right, having the lens to see the strength, thinking about, okay, how else, or what else can I do? Is this the right way to do it? Is there any other ways to do it? Sometimes parents come to me, they have all the answers, but they probably are not reinforced saying that what you're doing is right. And when we do that, a lot of things changes. Parents know the answers. This mom knew every time she talks about snakes, we get a lot out of her. She can attend for hours. She knew it. Yeah. So, but again, having that, having that advocacy from parents, changes quite a lot. Yeah. In terms of how our kids function. So going to neurodiversity affirming language and practice. So say, for example, we say she suffers from autism. So this is the language that, not really neuroaffirming. But we can say he's autistic or he's a child on the autistic spectrum. That's neuroaffirming language or neurodiversity affirming language. Other thing that people, a lot of the medical model, we say fixing the problem, fixing the symptoms. Whereas you can say supporting the child's needs. Yeah, so there are language difference. There are language that you use to demonstrate the strength. And that's what we call it neuroaffirming language. So earlier we talked about high functioning, low functioning. And then, as opposed to that, we can talk about, he needs less or more support in her daily life, or he needs less or more support in daily life. Yeah. So other example could be she has a challenging behavior, or we can also talk about she communicates through her behavior, isn't it? So behavior, as we slightly discussed, is a manifestation of what's underneath, isn't it? So next slide, please. Any questions so far? So I keep asking this question. I have a lot of questions. So what do we do after we get diagnosed? Obviously, I can acknowledge a lot of family members. They look for speech therapists, occupational therapists, physiotherapists based on child's needs, and then seek support, right? Or sorry, psychologists as well. Sometimes dietitians, sometimes food specialists. Jointly with the OTs. Yeah. So we see that. And when we talk about explored accommodation, what I just did, and something to note for all the parents, for the kids who go to school, there's something called CRC Australia, right? They're one of the biggest research body in Australia, and then they do provide recommendations. So they have released the recommendation in the last 10 to 15 days. And when I reviewed the recommendation, which was in line with what I've done with this girl, yeah, that means follow the child's interest, change the curriculum based on what child likes, yeah. So I had another client who didn't go to school for almost whole term, completely disengaged, yeah. It took me 2 meetings to get him to the door, and now he's going part-time, 3 days. This happened in the last 3 months I'm talking about. Yeah. So towards the end of last term, he started going. That was a massive achievement. And the changes that happened was what was making him feel unsafe and what did you do to make him safe? So that's accommodation. And that's what we tend to do. We tend to investigate, what's making him anxious. Teachers say everything is going fine when he's here. He says hello to everyone. He's very chirpy, this. But then is the child masking a lot of things that's happening at school, whether the education is getting really high, because we know kids with autism and ADHD will have a lot of struggle. They are putting 3 to 4 times more energy to learn same thing as neurotypical kids. Yeah. So something to keep in mind. Yeah. And connecting with the autistic community, it's very, very important. So I think a lot of my kids also had joined online groups where neurodiverse mentor do mentorship, more like a role model, talking about symptoms. This is how I manage this, this is how you manage. This is my strength. This is what I like doing. Because if you see the journey of our kids, a lot of the time, it's all like negative, this is not working, that's not working, you are not doing well, she is not doing well. And it's a lot of, like negative connotation attached to them throughout. Yeah. So there's no venting. There's no coming out of that, right? So I guess we need environment, we need atmosphere where we talk about strength. Yeah. So that's very important as well. In all forms. Yeah. So again, that's very crucial because a lot of things lies, the behavior lies within that. Yeah. What do we do in the meantime until we get to the end of our course in 3rd of December 2025? That's when we finish our course. So I think we can look at that, firing and wiring. Look for connections. Find the moment. If your kids are playing certain games, inquire, be curious, try to get into their world, build connections, because what we know, when we are connected, we're regulated, we're feeling safe. More we connect, more neural pathways forms, and that network of neural pathway keeps you calm. And that's when you are, you are developing emotional regulation, which is, like highlighted challenges with family members all the time to us. Yeah. So that's what I would, recommend take away from today. And again, taking all the communication as very vital and important because there's a message hidden within. Behavior is a form of communication. I'm not feeling comfortable. Something is making me quite stressful. Because the behavior, likely I'm getting traumatized by certain things. So just be aware, just be mindful. Yeah. So focus on shared joy and connections. So when you have that moment where you both are laughing, that's when things are happening. Brain structures are changing, and it has been proven. We have got a lot of research to back that up. Yeah. So think about how to provide a child with sensory information that benefits them. Think about if the child lacks one of the sensory information, and as Julie mentioned, that it could be, under responsive or over responsive. If they're under responsive, they're probably seeking more. That's why they're moving quite a lot. Yeah. Think how we can provide that sensory input right now, right here, until we learn about sensory world in next session, next week. Yeah. Next slide, please. All right.
Just some resources for everybody. Yeah. Did you want to highlight some of those?
Yeah, I think I would highly recommend ICDL website. And other thing that pops out in my head is, the things that I just mentioned from, Autism CRC, because they do a lot of research. So you can find a lot of articles, information. There are a lot of short courses in positive partnership as well. They can be quite useful. Raising Children is quite a reliable website. There are a lot of information around how to, social stories and all that. They have it in there. Even positive partnership have those informations. And Amaze is really good because you can talk, you can, as a carers, you can call them, you can find answers. So you'll find a lot of families that share the same stories or have solved a lot of things that you may benefit from. So I think these are very important resources that we respect and we visit in a therapy setting. And highly recommend the #1 book. If you haven't purchased it, it's available online as well in book form. I would today. Yeah. And that's the best thing that I've done to understand the brain. Yeah. As a therapist.
And I would highly recommend #4, the Affect Autism podcast.
Oh, yes.
So if you're autism, it's run by a mother of an autistic child and has different kind of subjects and topic areas and stuff like that. It has a huge library of discussion. So that would be my #1 recommendation. I put it in bold there. And then, yeah.
And it's available in Apple podcasts as well. And yeah, you can access either way. And it's really useful. as a therapist, I always learn from that. Yeah, and I always go to that. When I'm driving, that's what I'm listening. So I would go definitely. Yeah. So Greenspan, Dr. Greenspan is the one who's with Dr. Sinina Wida, proposed the DIR FLOORTIME model that I was just preaching earlier. So please visit ICDL and find out. And there are a lot of radio shows, right, that he has.
Yeah.
Within
Original radio
ICDL.
shows. Yeah.
But it's amazing. It's amazing. There are a lot of videos that you can watch as well. Yeah.
Yeah. I think that is. And then these are just the references we used for today's slide. So I'll stop sharing there. I just want to thank everybody for their flexibility while we figured everything out tonight. I hope you got some beneficial moments of information around it. And then just the next modules are kind of set up in that idea of those little pie pieces. So sensory processing and at the beginning of floor time, and we're kind of going to work our way around the pie a little bit. Other than that, we're here for questions and answers. PJ, is there any other logistics? So feel free to stay if you have a question. If not, I know we've taken quite a lot of your evening time and you can head out, but we are available if you have any burning questions you want to ask today. And then if not, I'll see most of you next week.
Yeah. And you can even maybe it will form something that you can post your questions as well, so that so that it will come to us and we can attend that separately as well. If you have any questions that probably you'll have after the session, you can always send an email to us and we'll respond. Yeah.
That's good too. Does anybody have any questions they would want to ask?
Now I think I'm an AFK.
Actually, yeah, I'm not exactly the same age group as your triplets. And yes, but I have actually had I do have a couple of older kids as well, so I've been through that bit before. But I, differently to a couple of the parents here, I've got one just only just touching base with the OT now, but we've got the journey of going into high school next year, and yeah, but still not very. Yeah, we're sort of really struggling with that whole, wanting to go to school at the moment. Yeah, and but it's also a new school as well, so it's like not even knowing what it is that she doesn't really like about school. How do I get her to sort of, I don't know, help me out with, I don't know what it's like at school as opposed to what it's like at home.
Yeah, that's a great question. The first question I kind of would ask around you is, are you having good communication with the school itself already? Is there anyone there that you can use as a supportive contact?
Only just sort of really started to touch base with them because it's a new school, second half of the year, but I think because she masks a lot of the time at school, they're like, oh, we didn't even know she was worried about that kind of thing.
Yeah.
That's not what we're seeing at school.
Yeah. That's a common story. That answer is, that's not what we're seeing at school. So has she been able to look at the new school and visit yet? Because a lot of that, I'm sorry, PJ, if you have a different thought process, I would always contact, so almost all schools, I'm going to say, have some kind of a special needs coordinator that exists within the school system, even if they're not directly at the school. So make sure you find that person and have that personal contact with them. But a lot of what happens is that unknown piece can be quite destabilizing for individuals. And so trying to figure out, it's almost like you don't need to know what's making her uncomfortable as much as you need to be able to help support her with what it might look like and what the options might be. So sometimes the uncomfortableness comes from the not knowing versus anything else. And so as much as you can kind of support around the knowing, and some secondary schools will have a video of the school where you can sit there and go, can I get a video of the classrooms, and can we get on a Teams call with her new teacher so that she's meeting her contact person before the transition happens. And so just sometimes, you know, when we talked about that slide about the presentation might look like anxiety and fear, even though it might more be about the executive functioning of visualization and problem solving. And so that's where my brain goes in those moments is, you know, how can we create as much known content in an unknown environment? And it doesn't have to be going to that school and having a tour and having to figure out that environment. It can be, you know, a lot of our kids learn through technology, don't they? And it's a safe place for them to have those interactions on a phone or on an iPad. And so it might be a video versus a physical tour if she already struggles with some of that motor spatial awareness stuff. Going on a tour is difficult, but seeing it in a video might not be. Having a phone call video chat or, you know, a message might be easier than going and sitting in the counselor's office to meet them. And so I think what I would encourage is to navigate around what can be known, and then it might be those other things. And most schools will help you have, supposedly should help you have some kind of graded entry. So the first day you're only going to go in for 2 hours and I'll pick you up, you know, or you know, or you're going to go in for the last 2 hours. And so everyone else is already settled into their day. So, you know, I would really encourage you to have those conversations with the support staff there, and ask for every accommodation they can suggest. And, you know, just go like, what is the most you can offer me? And then let's decide what we don't need versus saying, oh, I need more. Oh, I need more. I need more. You didn't know you were signing up for an advocacy course as well. But I find that parents are you know, that is one of your major roles in life is advocacy. So I think have those strong conversations early and ask them for some of those supports that aren't increasing her energy spend. They're decreasing her energy spend. And that's, you know, Taylor Swift is just rocking me today with this quote. So I think that's where I would start that conversation with them. And then maybe once she's out of the worried stage, she'll be able to identify what the worry's about. But really, it's difficult for any of us to identify the cause of the anxiety when the emotions are already escalated. We really don't problem solve very well when our neurotransmitters are taking over our thinking. So that might be where I would start. And I would wish you luck with the process as well.
Thank you. Thank you. Yeah, I forget to ask sometimes, or ask what to ask. Yeah. Thank you.
Just say, what's the most you can give me? And then let's work backward from there.
Thank you.
What Julie mentioned is IEP, Individual Educational Plan. And you ask very specifically that let's have an IEP meeting. Yeah. But also, you know, going back, and I would like to investigate how the primary schooling was. She had a lot of, you know, positive things happening in the primary school, right? But if we had ongoing challenges in the primary school, that means, you know, we already have some trauma and anxiety from this, which we tend to take to, you know, secondary school. So a relationship breakdown with the friendships, having to form new relationships. It's just like we're starting a new job, isn't it? How anxious we become on first few months. And that's when we start to settle, you know, and same thing, but our kids have in higher intensity, isn't it? And that's what looks like a panic, not wanting to go. So we have this reaction in fight, flight, and freeze mode where we are trying to fly away, not going. Yeah. So as Julie indicated, you know, I think if you have professionals around you, get them involved. You know, if you have an OT around you, get them involved. You know, try to, you know, tap onto all the strength that she has, and then work up from there. And make the plan together with her. It has to be collaborative. What may be easier for her right now, right here? You know, can we do one of the favorite activity when she gets there? You know, so that calms her anxiety down. Can she form a relationship with the teacher? When she goes there, she spends some time with the teacher. So the teacher becomes anchoring point for her when she goes to school, right? So these all becomes really crucial. And I had a kid very quickly. I had a kid because I talk quite a lot. Less than Julie, but more than everybody else. So I guess I had a kid who refused to go to school because he did not have a friend when we changed the school, right? And I went to this school to give training, and we started investigating. Okay, why is this in particular refusing? Because he did not know, because with this friend, when this friend is going, he's going, but when this friend is not going, he's not going. That means he was relying on his friend's planning. He was struggling with planning by himself. He was feeling bored. He didn't know what to do. He didn't know what to, and there was no one to scaffold that for him. So when we came up with a solution to scaffold that and making a strong bonding outside school, that's when he started going to school. So finding out what is it for your kid, yeah? And being an investigator, being a detective, and that's what you do with your professionals to find that answers, yeah?
Thanks for that. Thanks.
I agree.
Any other questions?
No, I just stayed to hear, but I hope that was okay.
I love to hear the questions. It's okay. It's fine. I hope that, I think I mentioned that there might be a form that comes out after the class just to kind of check whether the level of knowledge and was helpful, appropriate, to you guys. But if there are no other questions, we will see you guys next week for sensory processing and its introduction. I've called it a glimpse because I'm going to struggle to squish it all into an hour and a half, but we'll at least get to the point where you have some good questions to wonder about and think about needing support around. So that's the plan for next week. See you same time, same place.
Thank you.
Thank you.
Thank you for both of you.
Good time.
Good night.
Giving it a really good thoughts before making the video. We are also offering midway entry. So we have already done our module 1, that's understanding autism, diagnosis and core concepts. So module 1's video is released, and you can, within this form, you can click the link, access the Google form, and you can access the module 1 video for free. And if you feel that the interaction and what we have proposed in module 1 is helpful, then you are very welcome to join in. And so we are welcoming midway joining in for the upcoming topics, which is sensitive processing, supporting communication, motor planning and play, executive functions, connection before corrections, understanding the why behind the behavior, and additional supports and resources. And the final one that we have is feeding intervention in autism or ASD. So we would love to see you if you're interested, because definitely we believe this is going to be highly beneficial for the families who are out there in the country. So we're going to post this video and see what happens. But please click the link, access the video. Even though you're not interested in all other modules, you still get something out of our first video. Thank you. Thank you.